No problem.
All right, well, good morning, everybody. If you can work your way down to a seat, we're going to go ahead and get started. This morning's presentation is the beginning of the 14th Annual Research Conference in Nutrition, Gastroenterology, and Surgery. This is supported by the Department of Surgery and the Division of Gastroenterology, as well as the Surgical Nutrition Service. The goals are to facilitate clinical and research collaboration in nutrition across surgery and GI disciplines. This morning, I have the delight of introducing our speaker, Scott Shikora. Scott is Professor Emeritus from Harvard. He has done a lot of amazing things in his career. He's been the director of the Center for Metabolic Health and Bariatric Surgery at Brigham and Women's Hospital. He's been past president of ASMBS, which is our U.S. society, IFSO, which is the International Federation for the Surgery of Obesity and Metabolic Disorders. He's been past president of ASPEN, which is the Parenteral and Enteral Nutrition Society. And he's been editor-in-chief of Obesity Surgery for 15 years, and associate editor for SWORD, which is our other bariatric journal. Pretty amazing. About 500 publications, over 800 presentations. And I got to meet him when I was a fellow. I don't know if you remember this. We went to the Medtronic Fellows course they used to have for the bariatric and general surgery and MIS fellows. We went to Medtronic's place in Connecticut, and he was my proctor in the animal lab. So we go way back, and we've been friends since that time. And we're delighted to have you speak to us today and tomorrow. But today's on the ASMBS and IFSO indications for metabolic and bariatric surgery.
Thank you very much. I want to thank the team who took me out to dinner last night. It was wonderful. It was very nice meeting everybody. Some people who I knew, some people I was meeting for the first time, and thank you very much. This is an incredibly important topic. I believe, and bariatric surgeons will likely agree with me. So if I get really emotional up here, that's part of the territory with this topic. And we're going to talk about these new guidelines that you may not even know exist, that we're trying to get the word out, that we fought very hard to get accepted by society, because the current guidelines are 36 years old, and nothing else in medicine that we're still doing has guidelines that are 36 years old. So here are my disclosures. None of them have any bearing on this presentation. So I want to start by asking you some questions. Let's go back to 1991. You'll see why in a minute. Do you remember 1991? Were all of you born in 1991? Well, if you remember some things about 1991, you might remember this movie, Dances with Wolves, with Kevin Costner. If you're a parent, you may have mourned the passing of Dr. Seuss. We had a war then, just like we have a war now. That's the Iraqi war. And I was finishing my training and heading into the Air Force. Now, I didn't fly the plane. In the previous slide, there was some tanks and some planes. But I was a physician at one of the military hospitals, and I was on active duty for 4 years. This is Vice President Gore, and he did not invent the internet, but he told everybody he did. And the Soviet Union broke up into Russia and all those little countries. And something very important happened in bariatric surgery. The National Institute of Health developed criteria for who we can operate on and who we couldn't operate on. The insurance companies grabbed onto it like you couldn't believe. So there was no wiggle room to say, but this patient really needs the surgery for the following reason. Insurance companies didn't care. Either they met the criteria or they didn't. It was that black and white. And these criteria were based on data that was published 10 and 20 years earlier than that. No laparoscopy, no robots, a lot of the things that we currently have available to us. So it was a difficult time. Plus, there were only two operations being done. Open gastric bypass, which I bet nobody in this room has ever seen, let alone done. And the vertical banded gastroplasty, which was an operation where you put a band around the top of the stomach, and it was sort of like an optical, now I guess, band, like the adjustable band that we had a few years ago. So what's changed? Well, I did have a phone like that picture over here, and it was pretty big and heavy and didn't work very well. But now we've got smartphones. And we've got all new ways to treat people with stem cells and gene therapy, and all that's evolving. We can now have men not be embarrassed about having ED, because we got the little pill, the little blue pill. We can do stenting of cardiac arteries where we don't have to do cabbages on everybody. And here's the biggest change. This is the money ball right here in this field, and I think in most fields in medicine, and that was a conversion from open to laparoscopic. It changed the world. Now, we're no longer building robots for television programs, but I couldn't find an old picture of an Intuit robot that was reasonable. So that's the robot from a show that used to be on TV called Lost in Space. So what's changed? This is from Dr. Buchwald, who's one of the fathers of this field. What's changed in bariatric surgery? You can see it's actually a considerable list. We know more about obesity. We know how to take care of obese patients, and we also know how to take care of them when they have surgery, how to take care of them when they leak, when they get sick. We have new operations. It's no longer just two operations, open bands and open bypasses. Now we can do sleeves, which is the most popular operation in the world for bariatric surgery, SADIs, and still doing a lot of gastric bypasses. We have improved safety with these procedures. We've got better equipment. We have better management of patients because we know how to take care of them better after surgery. We have 19 years more experience with the disease than we did. So as you can see, it's a pretty long list of what's changed. What hasn't changed? The guidelines. This is 2026 right now, 27, I'm sorry, 27 right now. We're using the same guidelines across the world that we were using 36 years ago. There's got to be a problem with that. So let me now go into what happened. And I take you back to a couple of years ago, 2000, around 21. I had just been made president of IFSO, the International Federation of Surgery for Obesity. IFSO is the world's version of ASMBS. ASMBS is one chapter in IFSO, and that chapter is North America. And IFSO is the entire world. They're both about equal in size because in the United States, the IFSO chapter is so much larger than the chapters in, say, Spain and Germany. So IFSO has almost as many members as ASMBS. But in any event, when you come in as a president of an organization, you usually have something you want to do with your time, a project you want, something you want to get changed. And in my book, it was the guidelines. I hated these old guidelines. They were worthless. And I very much wanted that during my year as president that we make at least steps towards getting rid of the old guidelines and bringing in evidence-based guidelines, real guidelines, and not guidelines that have 30 years of history behind them. So I was telling people at a meeting that that's what I wanted to do. And somebody said, Shanu Qatari, one of our colleagues, in North Carolina had expressed the same interest, and he was president of ASMBS at that time. So I hunted him down, and we sat and had coffee, and we talked about it, and we were on board, both of us, with making these changes. So now we got to just convince the societies to let us go forward. Now, what we were changing is this. Prior to 1991, it was the Wild West in bariatric surgery. And us older folks remember operations being performed you never heard of before. A surgeon does an operation once, writes a paper, says, I had great results. Some other people then tag it on. And now we're chasing these horrible procedures. And that went on for years. So in 1991, the NIH was approached and asked to come up with legitimate guidelines. And here are the guidelines, unchanged and still used quite frequently today by insurance companies. But basically, the bottom line was BMI over 40, you can have the surgery. And 35, if you had severe complications of your obesity, such as diabetes or high blood pressure, sleep apnea, the usual crowd. You had to have attempted repeated failure, although they never explained to us what were we failing. No history of psychiatric disorders. They wanted patients seen by a psychiatric person. And once again, go back to doing old surgery, open surgery, where a leak is totally different than it was today. Now, they came up with those guidelines, and a few years later, they met again. And in this meeting, a couple of things happened. Number one, they decided not to update the guidelines, that they wanted to stay with the guidelines that were now in this setting, 7 years old. And this is the comment they made, and I highlighted part of it because this is from the National Institute of Health about their own guidelines. Thus, some of the material is likely to be out of date, and at worst, simply wrong. Those were the guidelines at the time, simply wrong. So how did they come about that? They had a 2-day meeting, and it consisted of the experts in the field of bariatric surgery. There were one surgeon out of the 14 members of the panel and a retired surgeon. So basically, you had 14 experts telling everybody how to do surgery. There were 20 presenters, 14 surgeons with experience in obesity surgery, and then after each presentation, they discussed, at least they discussed it. And they developed a panel that then came out with those guidelines that I showed you before. And the guidelines were basically opinion and old data. Think about it. If you're looking to write an article about data that was published, up until recently, the data that you would have gotten out of the computer would have been data from the 70s and 80s. So now you have data from the 70s and 80s and a lot of opinion, and you're 36 years later and nothing's changed. It was painful and it was difficult, and it held the field back quite a bit. And we decided that we were going to do evidence-based medicine, real medicine. We were going to go do the research. We were going to pull the articles. In all fairness, there weren't many articles, and there weren't many articles that had more than 20 patients, 25 patients. That was considered a big series. But be it as it may, we had the care from decades ago. Nobody had any stomach to update it until they hit our societies. So those are the main reasons for the change. The old guidelines, by the way, was very heavily biased by BMI. And as I'll show you in a little bit, BMI is horribly inaccurate and does not represent adiposity. So the problem with BMI is it also discriminates against certain people. It discriminates by age, so it's less favorable to older people, gender, race and ethnicity. And if you're Asian, you really get hit by this because they knock the BMI down by at least 5 points for Asian people when it should be the other way. And I'll show you what now we believe that because of genetics, et cetera, people from Asia should actually be considered for surgery if they have diabetes and other health issues at a lower BMI than 35 and 40. And the new guidelines reflect that. The other thing is BMI in one person is not the same as BMI on another person. And these three people all have exactly the same BMI, but look at their shapes. They definitely are not similar. And if you go into the data in the literature, you can see slides like this, that the BMI discriminates once again by ethnic groups, and in particular Asians, but also by Black Americans and Caucasians. You can see there's a difference. Gender, once again, there's a difference between men and women. So that was our charge. The two societies got together and we created a writing group that consisted of members of both societies. And within the group, about a third of them were past presidents or presidents of these societies. So we were taking the most likely to write well, the most likely to do correct research. And we set out for paper one. Dan Eisenberg from California was the lead writer on it. And we got the group together and we divvied out the assignments. And this was what we were doing. The current criteria were outdated and based on bad data and based on no science. And our goal was to create scientific, evidence-based guidelines that reflect the current reality. And the two societies actually probably worked together on this paper the first time they ever worked together. For most of the early years of these two societies, they were competing with one another. There was not always good blood. There was some bad blood between the two. And this brought us all together and set us up for future working together. And that's the writing group. And that's what we were intending to do, that we were basing this on science with some best practice and some opinion, but we certainly didn't want that much opinion because the opinion was just, that's what I think we should be doing, is that's not how you write guidelines. So the new guidelines were going to be evidence-based. We went into the literature, we did a deep dive, and we pulled out quite a number of prospective randomized trials and meta-analyses, which they didn't have, in all fairness, in 1991. We now have quite a literature, quite a large literature with high-quality studies with large numbers of patients. Instead of 25 patients and calling it a big series, we were looking at meta-analyses that there was 1,500, 2,000 patients, 10,000 patients. So, and we looked at these various groups because when we sent our statistician in to look at the data, these were the groups that showed a good quality, that we had a lot of data, that we know we could write reasonable papers from. And it covered the issues that I mentioned before, you know, the elderly, people with diabetes, Asians, et cetera. And just more of an explanation of the same thing. So we wrote that paper, we got it published, and lo and behold, we started to see movement of some insurance companies, Aetna, some of the others adopted it. But we were also told, well, how do we know you have good data? See, in bariatric surgery in the past, there was such prejudice against us that if you wrote a good paper that had good data, somebody's going to quote you and say, well, you know, it wasn't really good data. So we're not going to follow those guidelines. But in any event, we had good data. We just needed to prove it. So we had a statistician, Maurizio De Luca from Naples, Italy, look at all our data and said, all right, we need to write the paper now to show everybody that the data was good data. And we were concerned that this was going to sink everything. So we looked at all this, what was in the literature, and we came up with 11 criteria that we could show evidence-based using statistics that this was strong data. And there were a couple that we couldn't show, and I'll show you that in a minute, not because the data was bad data, but there wasn't enough of the data. So here are our criteria, and I want you to look on the right side. And what you see here is the level, the quality level was no less than a B for basically everything with some A's mixed in, and only one that was below that. And the grade also, all the grades were A's and B's, mostly B's, but a lot of A's. And we thought that was a tremendous victory. Now, BMI greater than 35 and joint arthroplasty, there just wasn't enough data in the literature. So we did what's called a Delphi. A Delphi is like science, but it isn't the same strength as, say, a randomized controlled trial. What that is, it's a very involved getting the opinion of people who are experts in the field. So normally you pick like the top people in a certain field and you put them together and you fire questions at them, and then you look at their answers, you grade their answers, and you go through various cycles until you come up with a conclusion. Once again, it's kind of like data, but it's not really the same as getting a good paper that has all of the information in it. But it's the best we had, so we used it. And in those two areas, we could say that there's a very strong opinion based on one's experience that that is the case, that you can do surgery safely on those two categories, but it's not the same. The rest of this, what the data demonstrated in the paper was you can and should do surgery on those individuals if they meet any of these criteria. So the new guidelines came out, and we were very pleased that at the end of a 2-year period, 120 million covered lives were now using our criteria. And that was the big victory. And this year I checked in with ASMBS, it's 131 million covered lives using our data and not using the NIH database. So what's the future? I believe we need to convert what we now have to a living document, to something that we can upgrade or change every couple of years, that we're not waiting 36 years to update. We're doing it now every couple of years, like you would a textbook. Textbooks every couple of years now, they have to be updated because the information becomes old. The ASMBS, once again, will take care of North America. IFSO will take care of the rest of the world. That comes to about 10 million society members. So we should have plenty of people for writing articles. And hopefully we'll continue to cooperate with the two large organizations on projects similar to this, because that's the only way you're going to get things done. So the current criteria, in conclusion, the current criteria served us well for many years, but turned out that they ran their course and they needed to be taken out of service. And we needed to have a living document that can be updated every few years. Now, we don't have that yet, obviously. And hopefully this is an example of where we need to fight for our patients and not let insurance companies tell us what we're doing or using. And we need to use the literature that we have. We have a big database, the MBSA QUIP database out of the American Society of Metabolic and Bariatric Surgery has about 100,000 patient data. So you can go write a paper on almost any topic related to bariatric surgery with an extremely large number of patients and data to use. And I want to thank everybody again for inviting me today. And if there's any questions I can answer, I'd be happy to answer for you. Thank you very much.
Any questions? Go ahead.
Scott, thanks for coming and giving a talk. What's strange is that look at the new guidelines. That despite the fact that we used the BMI 40 guideline from 1991 as our criteria for bariatric surgery for 27 years, there wasn't level B evidence or above that BMI 40, you could recommend it with the strength. Why did 40 wash out? Was it that the other comorbidities kind of claimed a stake? Why wasn't 40?
Because there's nothing magical about 40. Is 40 different than 38? Where 38 gets denied, 40 gets accepted. Is 40 different than 41 or 42? So that was what we were trying to tackle, all this ambiguity where you're looking at one number, 40, and that's the magic number, and it's not true. What we also were able to write about, if you had heart disease, end-stage organ disease, and if we're able to get you to lose weight with bariatric surgery, you could then qualify for an organ transplant, which you wouldn't have otherwise, because the surgeons would say, well, your BMI is above 40 and this is really dangerous. Well, we actually found it wasn't really dangerous, that the patients did really well if they had bariatric surgery, lost weight, then had their transplant, heart transplant, lung, kidney, and they did really well. And I was involved with a number of them at the Brigham, where we came in, and even in a patient with an LVAD, we were able to do a sleeve, a quick down and dirty sleeve, get them off the OR table. They do pretty well. And then they come back. Well, some of them, their hearts recovered. They didn't even need transplant, and the others got transplant. And we could do that for pulmonary. We did that for cardiac. We did that for older people. You know, all of the subgroups that we were told in the past, no, because the BMI wasn't 40 yet. Yes.
So Scott, thank you so much. I appreciate the talk, but really more appreciate you changing these guidelines. They were out of date my entire career. And it's been refreshing that we're now actually evidence-based in what we do. You brought up one thing though on BMI being out of date, and I'm curious your thoughts on what would be better than BMI. And then the second question, I do foregut surgery too, and with reflux and somebody who's failed fundoplication, we try actually in some of those patients to do a bypass as the treatment of choice. How would you suggest getting that to be easier through insurance?
It's a very good question. I think you can have a statistician go through the data that's published already on foregut conditions and then see what they come up with, because it basically was just looking at it from a standpoint of like a meta-analysis, a giant meta-analysis, and see what's there. And also understand that the big picture with this isn't the individual areas, it's the whole field that said BMI sucks.
Yeah.
It shouldn't, it could be part of how you determine surgery, but it shouldn't be the only determinant for surgery, because you're leaving a lot of people out of it that surely would benefit.
Is there anything better than BMI that you would suggest using, or you think just in the looking at all their metabolic disease is really the most?
I think it's looking at the whole patient. I'm not sure of anything better than BMI, because BMI is not just weight, it's also body shape and size. And you could see I had Shaquille O'Neal, who weighs about 300 pounds, but he's all muscle. There was the other end picture was a woman who's like 8 foot something. So even though she looks slender, her BMI was still 35.
Yeah.
Yes.
So, you know, we have the same issue with BMI at the other end of the spectrum with malnutrition. Because it really doesn't tell us about the body composition and, you know, how much is muscle mass and how much is loss of fat and adiposity. In the nutrition field, there's been an explosion now in all types of body composition analysis. Re-looking at CAT scan and PET scan and other things to try to get to quantify the body components. Anything happening, because I just don't know the bariatric world.
No, well, I don't know of
Would
anything.
there be opportunity there?
There's always opportunity. I'm just not aware of anything going on now.
Any other questions? So before we wrap up, we will be having breakfast for Dr. Shikora up on the fourth floor of APC. So if you'd like to chat with him some more, that would be a great place for that. And Dr. Shikora, thank you very much
Thank
for
you.
coming to Brown. Chat. You're ignoring the chat.